Hello, my friends, and thank you for being here today. I've seen so many of you out there, a lot of our clients, and a lot out there in the discussion area of the insurance companies not paying on pulp capping, direct and indirect. Surprise! They haven't paid on pulp capping since I can remember. We took a deep dive into this, and we are going to discuss that, but we're going to have a deeper discussion on why you keep trying to battle the insurance company with that. We begin our podcast right there.
Computers are live, mixer is up, levels are good, equalizer is good, ready channels 1 and 2. Mic is live in 3, 2, 1, roll it. Welcome, listeners, to the My Practice, My Business podcast, where we teach dentists and their teams how to reclaim forgotten profitability in dentistry with our clinical business of dentistry training. And now, the host of our show, the clinical director at My Practice, My Business, Dr. Rob Thorup.
Well, folks, we'll never understand pulp capping and talking about the reimbursement rates from insurance companies if we don't talk about the history a little bit. So back in the 1990s, insurance reimbursements under our contracts for composite fillings, they dropped because PPO plans began to follow the Omnibus Reconciliation Act of 1989 like crazy, which placed reimbursements at the same par as Medicare. At least that's what they tried to get them to do. And so the Medicare reimbursements for fillings were extremely low, and that's where insurance companies started to place their reimbursement rates for our contracts. And then they moved them up from there just based on what we would accept as a practitioner for a composite filling. There used to be a code for acid, etch, and bonding. That's right. They did away with that one too back in the 90s, and that was a way for us to help get reimbursed at a higher rate for the composite fills that we were doing because we were getting slammed on them back then. Dentists discovered pulp capping as a way to increase reimbursements. Everything became an indirect pulp cap, and dental consultants were teaching us to do that. You know, if it's deeper than 3 millimeters, call it a pulp cap and put some calcium hydroxide down there or whatever you want to do, and call it a pulp cap. Okay, what was the difference between liners and indirect pulp caps back then? Not a lot, because we would use pulp capping material as a liner all the time. So what did dental insurance companies do in the late 1990s? They stopped covering the code for pulp caps, direct and indirect. They put the cost on the patient for business-savvy dentists who were not afraid to charge the patient directly for their services. And heaven forbid, the patient has to pay for their services. Most offices just stopped charging for it because they've been brainwashed that they only treat to what the dental insurance will pay for. And they think that's all they can do. But then the PPO companies began to place verbiage in their plans that stated pulp caps were to be included in the fills, and we couldn't charge the patient for them. That was the verbiage that was in there. Aha, the beginning of the dental insurance bundling tactics was born in the 1990s. So now we fast forward to 2010. Insurance reimbursements are destroying any hope for profitability with composite fillings now in the 2010s. Gordon Christensen with clinical research, he showed all of us that we were way in the red for our composite fillings with PPO plans. And in an article that he wrote in Dental Economics, he's like, you guys, you've got to just be faster. You got to do more fillings per quad. And the dental assistant needs to throw instruments at us with better speed and accuracy. That will help us increase our profitability. Well, my good friend, Dr. Christensen, look, if there's only a patient with one cavity in that quad and that's all they have, it's not like we can do 2 or 3 or 4, okay? And everybody's, beating the death out of replacing amalgam fillings. So we're seeing this generation come up that are pretty healthy. So you can't do more dentistry if more dentistry is not needed. And now all of us here at My Practice, My Business, as we've been teaching our clinical business of dentistry training courses, we've seen the amazing resurfacing of pulp capping again by other consultants out there. This kind of reminds me of Nobel Biocare's reinvention of what we simply called implant retained dentures back in the 1990s to their brilliant marketing of the all-on-4 system. Okay, it worked back then and it still works now, just with a different name. For me, I just do 3 bridges on 6. That my good friends at Nobel and Straumann actually sells more implants for you, okay? So maybe that's what you guys ought to be teaching is all on 6. Of course, they don't think patients can afford that, but that's actually for me and my patients, that's a better thing to do. There's no plastic, which makes my crown and bridge high-end labs super happy because they sell more crown and bridge, bridge, and patients can keep their mouths cleaner with having implant retained or having bridges on the implants instead of implant retained dentures, and it's better looking and they work out very well. But that story is for another day. I just love the marketing by Nobel because we were using Nobel implants even back then. We were doing our implant retained dentures, and they look great, and they're a pain in the butt, and you're married to the patient, but that's another story. I just attended a CE course sponsored by Brasseler last week and they covered pulp capping. I love the endodontic products from Brasseler, and I use them all the time. So let me tell you about the presentation first. I was just like, honestly, I was dumbfounded. The slides, any of you presenters out there, stop using dark backgrounds on slides and then using, and stop using font that's like so small that you have to have loops to read it. It was just unbelievable. The enthusiasm. This guy had the enthusiasm of a sloth, and just your typical instructor at one of the dental schools here in Utah, and that's who he was. And I'm sure the guy's brilliant, and I'm sure he's a wonderful endodontist. But it's like, oh my gosh, you're killing me. All of us were sitting there in the room, and he covered pulp caps. Then the slides were out of focus. If you're an instructor at a school, you ought to have the commensurate achievement and know-how to adjust the focus ring on the projector. And I don't know. Anyway, he covered pulp caps, and it was brutal. It was the same crap that we learned back in 1989 when I was in dental school. Direct pulp caps have about a 33% survival rate for 5 years before root canal therapy is needed. That's what he taught, and that's the way it's been forever. But indirect pulp caps with current products out there are doing a great job in preventing root canal therapy. So that was kind of exciting when I learned that, because I don't know, I should tell you why right now. I don't do pulp capping. I don't look at it as, I don't do indirect pulp capping. If it's direct pulp capping, it's a root canal. In my opinion, there's bacteria there. It's a microbiology thing. Remember your micro days. I'm not going to try and be a hero because the chambers will constrict, the canals will constrict, and then, they're off to the endodontist to attempt to get down those canals and do root canal therapy. I just don't do it. And if it's an indirect pulp cap, here's a plug for Clearfill SE Bond. I've been using Clearfill SE Bond and their products forever and ever and ever and ever. And I shouldn't say I've been using forever. I have been lured into trying other bonding agents, and every time I do, I get some sensitivity on patients. But Clearfill SE Bond, I don't get any sensitivity. And I do exactly what the manufacturer tells me to do with a little bit of Dan Fisher, rub it in, and make sure you scrub that material in, especially on the dentin. And I've had super deep fillings, okay? I've had the little pink smiley face looking right at me, and I've put 2 coats down, and nothing, no sensitivity. That stuff's amazing, So it's like, I guess I could code out a pulp, indirect pulp cap maybe, because I'm not using conventional materials that everybody else uses, doesn't mean I'm not trying to prevent a root canal from happening, and I'm laying down 2 layers of that super expensive bonding agent that you cannot get me to change. All right? So that's just my philosophy. Yours is probably different, and don't judge me, I won't judge you. So how do we charge a PPO patient for the service of pulp capping, though? And most plans state that it is to be bundled in the procedure. Some plans state that it is to be it's bundled, but this cracks me up. You guys, we pulled all the insurances on this over the last several weeks just to read what it is. It's like Delta's, no, you will never charge for bundling, and then there's other insurance companies that state that it's to be bundled. But if you take a before intraoral pick proving the need for indirect or direct pulp capping, and an after pick with the filling in place and an x-ray, they will consider payment after a peer review. Isn't that kind of like an oxymoron? Isn't that sort of a double standard? We will not pay for pulp capping, indirect or direct, but if you prove that you needed to do a pulp cap then we'll pay for it. See, there's the problem right there. What happened back in the 90s is everybody was throwing indirect pulp caps down and as a way to increase your revenue on composite fills, because that way you could at least break even or make a slight profit on composite fillings. And because of that code was overused and abused, insurance companies picked up on it, and then they just decided they weren't going to cover it anymore. That's what happened. And so now this is why you see this kind of crap going on. So when you actually have a patient that needs a direct or indirect pulp cap, there's a problem that you're going to face because they're not going to. It's just in their contract with you that they're not going to pay for it. Now, let's have some fun business facts to understand here for a minute. Understand the PPO companies cannot come between the doctor-patient relationship, and you need to stop caring for your patient on the dictates of the dental plan. Yes, I know what it states, that they are not going to pay for direct or indirect pulp capping. We're going to get back to that. If there is a medical necessity for a procedure and the insurance company doesn't cover it, that can become a whole new conversation with your patient. This happens in medical all the time. People wake up. 3, the bundling of services is potentially fraudulent, and I will not do anything that is fraudulent in my practice on my patients. Never. If there is a CDT code for a service and there is for pulp capping, and I perform that needed service, I expect to be paid for it. And 4, it's the insurance companies that don't want to lose money by covering pulp caps or anything else for that matter. So now that we understand those fun little facts, so how might you deal with this dilemma? Well, here are some options. If it's a direct pulp cap option, let's do root canal therapy. I'm not going to be the person trying to save that, and here's why. There's such a low success rate. The chamber and canal constriction that happens from calcification because of the insult on the nerve is a real thing. And I've had many patients throughout the years where I've tried to be a hero on direct pulp capping, and it turns out to be an endodontic nightmare just a few years later. And most endodontists would agree with me on that. And nothing is worse than a patient who has pain. All as they don't remember your conversation of, hey, we're going to try and be a hero, prevent root canal therapy, and we're going to do this direct pulp cap on the tooth because the decay went right into the pulp horn of the nerve, or it went right into the nerve, and you're young enough or your child's young enough. We're going to try and pulp cap this and hopefully get a good result. And the one thing takeaway that I did have from that doc from the dental school who gave that lecture for Brassler last week is the success rate is so low and the potential for pain is so high. Why are we doing it? That just makes not a lot of sense to me, but that's my philosophy. That might not be yours, and I'm okay with that. And I'm okay with any of you trying to be a hero and trying to save it. I just don't like the percentages of success on that, and I don't want a patient who's in a lot of pain, especially down the road. All they remember is blah, 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 you worked on my tooth, and now my tooth hurts, and you must have done something wrong. That's oftentimes what the patient remembers. And then you lose the whole family, they hate you, and that's usually the case. So then, if it's an indirect pulp cap, though, because you can see that pretty pink reservoir of ugliness staring at you, I like to give the patient choice. I'm a firm believer in indirect pulp capping. I just do it a little differently than most of you do. But the patient, that's like they pay for it because their dental plan will not. You're not doing it for free. I'm not doing it for free. I don't believe you should either. I believe that could be a conversation that you have with the patient and you say, look, your insurance company is not going to pay for this. And because they want me to bundle it in. And we know that the American Dental Association states that bundling is potentially fraudulent. I don't want to do anything fraudulent. Your insurance company, per contract, says that I should include it in the filling. I can't afford to do that. It's a procedure that takes me time and materials, and I'm already being reimbursed at such a low rate for your composite fill that I can't do that. But if you'd like me to try and prevent a root canal from happening, it's going to cost you an extra X amount of dollars more out of your pocket that your insurance company doesn't cover. And if you'd like me to do that, here's an informed consent with refusal on the same page if you'd like this procedure. Now, a lot of you are probably thinking, oh, Rob, you can't do that. You're contracted to blah, blah, blah. Well, yes, I am. But yes, if you knew what we knew, you know that you can push back against the contract. These are some of the things that we teach at My Practice, My Business, and you can do it legally and ethically because, again, it's a procedure between the doctor-patient relationship, and just because the insurance company is trying to prevent you from doing it because they are bundling it and say it should be added. It's just like buildups. They're telling you to bundle the buildup. You have to bundle the buildup with the crown, unless you can prove the need for the buildup. You see where this is going? I am the person that I have no problem because I know the rules of the insurance companies, and I'm happy to push back on behalf of my patient and for their benefit. But you do not have to do free dentistry, people. What if the insurance company comes back and says, you're going to have to include everything in an extraction, bone preservation, everything, and you're only allowed to bill an extraction. I know many of you will say, well, then you just don't take the PPO plan. You dump the PPO plan. Well, that's not entirely true, because when you sign a contract, there's also codes, descriptions, and fees for the things that they do cover. And when they try these exclusions and when they add them along the way, and that wasn't what you signed when you originally signed up for it, you could push back. And one more little trick, if you sign up for a PPO plan, read the contract. Read the contract. Don't hesitate to do what any other business does. Line item veto yourself. Remove stuff yourself. You do not have to sign things that you don't agree with. Other little tricks we teach here at MPMB. So, no pun intended, let's recap what we talked about here, okay? Back in the 90s, pulp capping was being taught by consultants. Do that. That'll help increase because technically, microbiologically, physically, you are indirect pulp capping if it's so deep because you never know where the pulp horns are, all right? So that was used and abused. Then the insurance companies came back and shut everything down. At least that's what they've attempted to do. And you can have that pushback, though, with the insurance companies if you know how to communicate with them and know what you're saying. So what does Rob do? I don't pulp cap. There are so many other areas you can increase revenue on composite fills to be profitable on those. And we teach those business techniques that the insurance companies have given us permission to do. There's way more ways to be way more profitable instead of trying to charge a pulp cap and having that big battle every time you do it with the insurance companies. There's so many other things you can do across the board and do it on every patient to increase revenue. Because if there's one thing that we do know for sure, we are upside down on composite fills each and every day. If you know your direct operating costs per hour and you look at what your reimbursements are for the composite fills you're doing on your patients and you look at how many you can do, how many composite fillings you can do in 30 minutes, 45 an hour, you're upside down, folks. You're not making money. Let us show you how to make money on composite fills so that you can feel good about doing dentistry, so you can enjoy doing composite fills on patients. And like our clients have said, we love doing composite fills now, Dr. Rob, because we're actually getting paid for them, and it makes you actually want to do a better job on them too. And that's what I love about what we teach here at My Practice, My Business with the clinical business dentistry training. We teach you how to reclaim forgotten profitability again in dentistry. Thank you so much for tuning into the My Practice, My Business podcast. You can find additional podcasts you may have missed that will help you with your dental practice at Apple iTunes Podcasts. And remember to become a subscriber to our podcast. Many of you have asked how to help support the My Practice, My Business podcast. If you have enjoyed the program and information you received today, the best way to help is to leave us a 5-star review. Thanks again for allowing us to be a part of your day.